Hi, good afternoon, everyone. My name is Marvin Kajy. I'm a third-year medicine resident from the Detroit Medical Center. And today I'll be presenting our challenging case from the DMC. It's urgent TAVR in the setting of severe aortic valve stenosis, complicated by cardiogenic shock in a patient at extreme risk for surgery. So first, I have no disclosures. So this is our gentleman. He's a 67-year-old guy with a severe aortic stenosis presented with decompensated heart failure from an outside hospital. He has a past medical history of hypertension, atrial fibrillation, CAD, sleep apnea, MR, and CHF. So we did an echo on arrival, revealed an EF of 25%. Aortic valve area was 0.94 centimeters squared. His mean AV gradient was 18.6 millimeters of mercury, RVSP of 55 mmHg. The mean echo was done, showed a mean gradient increase to 38 mmHg. Patient was evaluated by our CT surgery team. Unfortunately, given his high STS score, I believe his STS score was upwards of 15%. They deemed him too high risk for surgery, and so the patient was evaluated by our heart team, and our interventional cardiologist took on the challenge. So our goal was to implant a 34 millimeter evolved R core valve. So here you can see standard access using micropuncture technique of the right common femoral and left common femoral artery. Next, we proceed with the right heart catheterization. As you can see, right heart has significant elevated pressures. Next, we performed an LV gram. So consistent with decreased LV systolic function of about 25–30%. He also has some aortic valve insufficiency. So we next proceeded with the aortic valve deployment. So unfortunately, during the aortic valve initial deployment, the aortic valve was deployed in a too deep position, resulting in a partial deployment of the aortic valve and actually worsened the LV systolic function. What happened was patient became hypotensive immediately after initial deployment of the aortic valve, so he developed PA arrest. What happened was the aortic valve was emergently recaptured, and Impella CP was deployed, and we were able to obtain ROSC after 4 minutes. Unfortunately, despite Impella on maximum support, Impella CP on maximum support, patient remained relatively hypotensive and requiring elevated amounts of pressors. So decision was made to escalate care, specifically escalate mechanical circulatory support. So the interventional cardiologist decided to deploy the TandemHeart. If you look to your left side, here you can see septostomy being performed in preparation for the TandemHeart, and on the right side, you can see the TandemHeart inflow cannula being connected to the LA. And you can see the Impella. Up next, so after we had successful activation of the TandemHeart, Impella was removed, and the valve delivery system was again re-advanced. So here you can see the Impella system being completely removed, and you have the TAVR with the TandemHeart with good LV function, improved LV function. So here you can see the TAVR being fully deployed, and you can see the post-valve angiogram. So we performed a repeat TEE. LV function was stable. Patient required decreasing amounts of pressors. Decision was made to wean off the TandemHeart, and TandemHeart was subsequently weaned off in the cath lab. Patient was transferred to the CCU on pressors. He was extubated 2 days later after the procedure, and he was discharged to rehab 7 days afterwards. So this case, we think that illustrates the feasibility of emergent use of mechanical circulatory support during a relatively high-risk TAVR procedure, and advanced heart failure patients with severe aortic stenosis can benefit from TAVR with acceptable outcomes. I would like to thank CVI for inviting me to present this challenging case. If you have any questions, I'll try to answer them.
Great case. I'm sorry, I missed, what was the reason for selecting the TandemHeart versus another MCS device, like Impella?
Based on my understanding, the Impella CP can provide like cardiac output of 3 to 4 liters per minute. A TandemHeart can go as high as 5. As to why, like ECMO, for example, was not used, I think at the time point, there was no problem with oxygenation. Perhaps that would be my own rationale as to why they chose the TandemHeart.
Mm-hmm. Another advantage of doing tandem is that you can hook it up to the ECMO circuit and do ECMO via tandem. I think it's controversial whether TandemHeart decompresses the left ventricle as well as an Impella would, but clearly you proved here that your patient did well. Congratulations. Do you know what the left ventricular end diastolic pressure was prior to the TAVR?
28.
28.
Yeah.
Yeah. As many on the panel here will probably attest, it's very hard to predict which of these patients will have the exact response that your patient had. We've all done TAVRs on patients who have an LV-EDP of 28 or 30 at the start of the case, whether it's a Medtronic valve or Edwards valve, and most of those patients do well. But then every now and then we see this situation. And I think probably, interested to get the thoughts of everybody else on the panel, I think probably what happened here is there was wide open AI while the valve was, the self-expanding prosthesis was being positioned, and this patient, for whatever reasons, was not able to tolerate that. And that's one of the shortcomings of using this valve platform, where you have to make those adjustments. On the other hand, I'm sure we've seen cases of that happen with the balloon expandable valve as well. So challenging scenario, oftentimes does not go well, but congratulations that your patient did well.
Thank you.
Quick question. The second time, did you use a 29 valve or still a 30?
No, it was a gap 34 valve. 34. Yeah. I think the initial problem was perhaps it was deployed too deep, and that's why they recaptured it, obtained adequate hemodynamic support, then they redeployed it in the adequate position. And actually, after it was deployed in the adequate position, there's resolution of aortic stenosis, resolution of the aortic insufficiency, and MR also has significantly improved.
I think in these patients, if you have really high EDP and pulmonary hypertension, if you are across the aortic valve for too long period of time, these patients don't do well.
Yeah.
So what was how long did it take for you to deploy the first valve?
The first valve, I think it was 5 to 7 minutes, if I remember correctly.
Because there's basically no outflow at that time till the valve actually starts functioning. And, but difficult situation, but good case.
Thanks.